Let's start with something that, yes, what is the art of writing scientific cases? Today, I'm not going to tell how to take a case. I'm sure because we all are homeopaths, we all are learned homeopaths, from the junior most to the senior most homeopaths sitting among us. So it is imperative to teach you that how to take a case. And let me tell you, there is no definition that a case is the well taken case. It can be a two-line case, a single symptom case, which we read in organ as one-sided diseases, or it can be a 3 pages which we have filled. So what exactly is the art of writing that scientific case? Moving now, every bit of information is important when we talk of scientific publication. Now, this bit is important from homeopathic point of view. So I'll be correlating all the research talks with homeopathy, with Hahnemann's teaching, with Organon here and then. So this bit of information is important. Why? Because even Hahnemann, guided us to include each and every detail of the patient. Why? Because that is important. Sometimes, you have 40 symptoms in front of you and you only prescribe on one single characteristic symptom, or one rare symptom which you have seen in a remedy, or one symptom which was proven in the materia medica or clinical verification. So every bit of information is important when we talk of either case in our clinics or we talk of scientific publications. Now let us quickly see what are the case reports. We all present our cases, here and there. A case report is defined as the scientific documentation of a single clinical observation and have a time honored and rich tradition in the medicine and scientific publication. Now, let me take one example. We say that there are 400,000 registered homeopaths, 4 lakh registered homeopaths in India alone. Out of 4 lakh registered homeopaths, what if half of them write a case and get it published somewhere? Okay, let us talk that out of those, 50% are rejected. Still, we have 1 lakh case record published every year. And okay, let's go to a rigorous editorial process. Even from 1 lakh, another 50% are rejected at some stage. 50,000 case record. Do we publish 50,000 case records? No, we don't do that. We present. We discuss. We discuss on social media, on Instagram, or meetings like this, but we don't publish. Why? Because we know that there are certain limitations of those case presentations turning into a case reports, because these are single case clinical observations. Now let us move further. Now there has been boom to publish case record. There's an interest, but there is not much of the population is interested to publish that. Lack of interest. For example, let me give you my own example. I started Journal of Case Studies in Homeopathy, and I'm talking way back. I'm talking maybe it was 2013. It's been 10 years now. I ran that journal for 3 years in a row. Journal of Case Studies in Homeopathy. That was the first open access peer reviewed journal in homeopathy dedicated to case record. I had to shut it down. Despite having 4 lakh registered homeopaths, everybody's contributing research and cases, I had to shut that. No, I don't mind. There's no problem. It was a learning to me because I did not want to publish the case record without any aim, without any guidelines. So there is a huge gap between data and published data. We may be having, 50 cases with us right now to discuss, but do we have in one case in that guideline format to get it published somewhere? That is the problem. We see, I'm sorry, we see 20 patients a day, average 20, 30 patients. We see every day, every homeopath in India see that. So it means we see around 600 cases in a month, or we see 7,000 cases in a year. So we have that data, but we don't have that published data. So the need of ours is motivation. We need guidelines. We need implementation, right? And we need persistency. Now, how we'll cover these points later. Now, case report is important because of teaching purpose. Imagine if I have taken a case and I am not including any evidence. For example, Dr. Abhishek, in just previous slide, I joined like a couple of minutes back. He was showing the evidence, the scientific evidence that this was the case was presented. Now that is being used for the teaching. We are being taught that yes, you gave this remedy, and we learned that remedy, will try that remedy in our clinical practice. So that is a teaching purpose. You tell your students, I go to Sur College, I take the clinicals, we discuss cases there. So it is for the teaching, for research purposes. If we want to support and promote and save homeopathy, now let me, this is another big challenge coming in next 10 years. Save homeopathy. It is dying everywhere, from governmental level, from at market level, because there is lack of evidence. We talk of evidence, hona chahiye, it should be there, it should be there. Where is the evidence? Are we contributing to that evidence? Have we published some cases? And for improving the clinical practice. Why? Because when I'm discussing a case record, when I'm discussing a case record in a guideline, in a manner, in a matter where it resonates with the public. For example, if I'm telling you something, people are asking me question, it is a good platform where I'm improving my clinical skills because of that case report. And Hahnemann was the one who started with the case record things. He'll end up on the theory of MISM because of cases. He'll end up on theory of chronic disease because of the cases. He'll end up on clinical verification because of the clinical case records. And we still read those clinical records today even. Now, where exactly is the problem? We know the problem, we know the solution, but where is the problem? The problem is we need to take that step. Now, in scientific publications or scientific or the evidence-based research-based medicine, there is no place of tall claims. I can cure cancer. It is absurd. I'm sorry to say, but whosoever amongst us, if we say like this, I have cured cancer, then I'm sorry. We have treated a patient. I have cured an incurable condition. Maybe I'm eligible to have one Nobel Prize. I have treated a patient. That was patient's destiny, that he was better or maybe cured for so many months or years, or that duration of time. So tall claims should be avoided because these are not right ethically also and medical legally also. Second, statement had little value, because if I'm giving a statement, oh, this RS versicolor works wonder in migraine, this statement has little value because I am telling people are listening. Some people are trying, some people are not trying. So statement have little value. But when we come to recorded statement, they have values. For example, the patient's consent, the video evidence, the audio evidence, the patient's written statement, they have value. We know that this case was presented and we are respecting that case. We are clapping for that person. But when it comes to a well-written case, they are accepted and respected. Why? Because people know that you have gone away beyond your clinic or your clinical practice, and you have got this case published somewhere, presented somewhere. Even nowadays we are going to all the international conferences and we are presenting cases there. Evidence-based cases, they are accepted, they are respected. Why? Because people want to have that evidence. Nowadays, people are not interested in having statements. People are interested in having those evidence or the guided cases. Now, what constitutes a good case record? Is it the evidence-based nature? I have the pre and the post report. What next? Is it the presentation? I made a beautiful presentation of that pre and post evidence. Or is the language style or something else? I have seen I have seen best of the physicians sitting at the clinic, seeing hundreds of patients a day, but they don't have that time, to present a case somewhere. They don't have that. Some people say that we don't know computers, we don't know how to present, we don't know how to edit the videos. It is accepted because they don't have time. I respect that. So it is basically the balance of all the things. You should have an evidence. You should know how to present it. Sometimes people, presenting a vague evidence. I was looking after one conference a few days back at the Gwalior, and I saw one statement given on the screen that was wrong. That was wrong. So I pointed the author after the presentation that yes, whatever you presented is not right. So if you want to present like this, so it is the presentation also. It is the language style also. How to present ourselves. That is important. Now, sometime presenting a case on a social media, we consider it as a publishing. It is not. It is not a publishing. Discussing our cases on social medias, on Instagrams or Facebook. No, a scientific case record must be published in a peer-reviewed journal. Now, coming to the core, what is the art of writing a case record? I'm not talking about what is the art of taking a case. You are best at it. But out of that best, how to present that. Now, this art is something which we learn and master over time. Now, this is art. This Hahnemann taught us. It took 12 years for Hahnemann to discover the theory of miasm. And we want to learn that miasm in 2 days, in 2 months, in 2 years, in 4 years of BHMS. We are expected to be the master of everything. But let me tell you one thing very honestly. We learn miasm when we come to the clinics, when we actually prescribe medicine to a patient, not when we read those miasm lines in any textbook of the miasm. It is when the patient comes to us, we give the medicine, patient theek hua, nahi hua. There we learn. A well-taken case constitutes winning half the battle. We have been told since the beginning, since the earlier entry into the BHMS level. Even when I was a student, I took admission in the college in 2001, and this was the statement given for the first time. Okay, take the case. A good taken case is half winning half the battle. Now, the guidelines for case taking are given in the aphorism 83 to 104. I need not to rewind those or revise those guidelines. Master Hahnemann has beautiful given every guideline of the case take. Now, what the problem is, there's a difference between a case sheet and an evidence-based case record. What we have at our clinic is a case sheet. It is not an evidence-based case record. It will become an evidence-based case record when it would be appended with the other things like evidence, like how to present that evidence. For example, how to read ECG, how to interpret ECG, how to interpret USG. We have advised the USG before and after. There are certain changes. How to present those certain changes. So there is an evidence-based case record that is different from the case sheet. Now, the latter involves much work and constitute completing the case in every respect. A case writing follows the scientific methodology. इसमें कोई अलग चीज नहीं है. There's nothing different. It is the standard methodology which we all follow, but which we don't write. IMRAT, introduction. Whatever case we are dealing with, what is the introduction? What is the disease we are dealing with? This is given in aphorism 3. Knowledge of the disease. Without having knowledge of the disease, can you treat a patient? You can treat a patient partially for a few weeks, but you would be needing a diagnosis, a clinical diagnosis, a provisional diagnosis, a differential diagnosis, or a symptom diagnosis. Even you don't know about the nosological, what is, I don't know. But I know this is a cystic lesion. I know I'm dealing with the arthralgia. I'm dealing with this. I'm dealing with that. So I need that introduction. I have that aphorism 3 with me, the knowledge of disease, the materials and methods. How did I take the case? I went for the mentals. I went for the physicals. I went for the miasmatic prescription. I went for the keynote prescription. I went for the clinical prescription. I went for the targeted prescription. I went for the favorite remedy prescription. So that depends on us. I gave biochemic, I gave tincture, I gave repeated medicine dose, I gave LM potency. What? So that is material method. That is basically, if I simplify, that is our style of practice. And we adapt that style of practice for years together. Now, we do experiment for this line of practice or the style of practice in first 5 years. I have seen students starting from the single dose under the influence of legends, and then they come back to the repeated form. Why? Okay, sir, that was not our cup of tea. We think we should repeat medicine often. And I've seen the other way around. People starting with the multiple remedies, giving repeated remedies, and they come to single dose prescribing later in their life after 10 years down the line. So this material and method basically in simple word is your style of prescription. Now the result, only the patient giving statement, doctor, I am much better. And we have not got one ultrasound done. Can you present this that case of renal calculi somewhere? Or the patient was telling, sir, I had pain abdomen, I had pain in my right flank, and after your medicine, it was all fine. I did not go for the ultrasound. Can we process that case? Yes, patient is coming to us, but we cannot process that case because we don't have that evidence. Analysis. Over the time, I know that these many remedies work best in my clinical practice. We all do that. If I ask you your line of prescription, your style of prescription, you will tell me that for this, these are the remedies we generally use. So this is analysis. Discussion and conclusion. This we all do. We all do in our mind. We discuss with the patient. We discuss with our fellow colleagues in our WhatsApp group. We have a doctors group. Someone or the other, they put that, okay, fine. This is the report. This is the patient symptom. What can be the rubric? What can be the medicine? So all these things we are doing, but we are not doing it methodically. Moving forward, there are certain important points to remember. We do not publish, present, process each and every case of our practice. Now, this is where I find it very practical. If we have 10,000 cases with us, we will not publish those 10,000 cases. Nobody can. Nobody can. So what we do, we only select the well-treated or the well-written success stories. And very rare we present failures also. Like me, I usually start my class with a failure. Why? Because these are the steps to success. So be assured that we are not going to publish every case, but we are going to publish some of our cases which are very well written, very well taken care of, which were miraculous cure happened, and we are presenting those cases. Now, therefore, the case record chosen for the publication or presentation demand completeness and innovation. If you keep on presenting the same type of cases everywhere, I'm sure after a few weeks or few months, people will not call you for the discussion. Everyone needs that completeness, that innovation, the style of prescription, the potency, what better you did with that case. So that betterment it should start from us. Moving further, an innovative clinical question may be derived from this is a basic about research, area of choice, interest, phenomena, or uncertainty. If we want to have a well written case, for example, I like treating PCOD patients more. I have an interest in dealing migraine patient. I observed that in the cholelithiasis, these remedies they work better. I know that these, for example, post-COVID arthralgia, it is area of uncertainty. So all these things we do and we should do. We should have that, area of uncertainty for research. We should have that observed phenomena. For example, the best example for this observed phenomena was Hahnemann's phenomena. When he observed the cinchona bark, that it is not acting because it is a bitter in taste. It is acting because it has some similarity in action. So for that observed phenomena, and that he moved to uncertainty. What happens if I give the other medicine in diluted form? And let me tell you, he was not potentizing medicine at that time. He was only diluting medicine. So he started recording those cases. Now you can imagine the power of case record. If Hahnemann would not have recorded those cases, that time we would not have been, sitting here discussing homeopathy in a methodical way. Now, a good clinical or research question should meet the final criteria. What is feasible, interesting, novel, ethical, and relevant? A rare case came to us. I know it is not feasible for me to handle that case. I should give up on that case. I should refer that case to a senior, to an institution where it can be handled. And I'm very clear in that. I don't experiment with the cases, at my clinic. If I know that this patient, this case needs, a better, you can say a line of treatment or a better physician or an experienced physician, I refer that case. Interesting. Whether the case I'm going to present, it is interesting, it is novel, ethical. Don't go beyond ethics. Do we take consent from the patient when we present the cases? As a rule nowadays, we should have that written or verbal assent and consent from the patient before even presenting anywhere. So that ethics should be followed. And what is the relevancy of that? We are not going to publish the cases on URTI, on cough and cold. Nobody's going to do that, because we treat cough and cold just like anything. Every other day we see hundreds of patients of cough and cold. So do we publish cases of cough and cold? No. We might publish cases of sinusitis. We might publish cases of rhinosinusitis. We might publish cases of impacted foreign body in the respiratory tract, or maybe a cyst, vocal cold cyst, or laryngeal papilloma. But we don't publish cough and cold. What is the relevancy? Now, is a case record part of clinical research? If yes, how? Now, this we discussed in the last slide or the last presentation when we had a presentation on research, that there is only a thin line between the same. In clinical research, in clinical practice, we use established treatment, while in clinical research, we collect evidence. If we are giving belladonna for headache, it is clinical practice. If we ask whether belladonna will work in headache, it is clinical evidence or the clinical research. So when you convert your patient's faith into a question, that becomes your clinical research. I'm skipping these points because these are important from research point of view, but yes, quickly, endpoint. We cannot present a case that we followed the case for 5 years. Do we do that? No. We present cases, those were taken the quickest in the shortest period of time. I'm treating a case of psoriasis for the past 10 years. I will not present that, because as an evidence, I should have an endpoint that I treated that patient for 6 months and this was responded or not responded. There should be an end to that point. Maybe you can treat the patient for 5 years down the line, but when it's come to presentation, you should have that end point. आपने कब तक किया? What was the outcome measure? Did you see the HbA1c in diabetes? Did you see the subjective well-being, quality of life in the patient? We all ask. It is just we need to write it down. I think we can skip these points because these are in depth, from research point of view. Now, I'll show this slide quickly. We have an incomplete picture with us. We have cases, we have case sheets with us. It is an incomplete picture from research point of view. What can complete this is the methodology, the language, and the guidelines. Now, this is important. If we are following a methodology that we've properly followed the case for a particular period of time, for a particular line of treatment, giving the particular remedies, potency, this, that is methodology. That style of prescription is important. That proper language is important. If your language is not right, nobody's going to accept or even listen to your case record. And did we follow any guidelines? Now, the guidelines is important because they constitute towards completing the picture. Now, one of these guidelines are case record guidelines. We call them home case guidelines. Making a case a better case. I was one of the experts when these guidelines were developed. So there were a Delphi rounds of discussion over long, periods of time, over months. And gradually and finally, we came across that these guidelines are important. Now, let me tell you, sometimes we are afraid of guidelines. Who will follow guideline? We have hundreds of cases in our clinic. Do we have to follow guidelines in every patient? No, it is not. It is for only those cases which we are going to present or published. वहां पर हम लोग को इन guidelines की जरूरत है, because these guidelines are just like criteria which sharpen our skills and presentation. 10 years down the line, 15 years down the line, 20 years down the line, who thought that we would sit on Zoom and discuss? No, nobody thought of, but we adapted to that. And let me tell you, pre-COVID, I was discussing the same thing with one of my colleagues. So the next boom would be the online classes. And this happened, this materialized, and we adapted to that. So day will come when we would have to adapt to these guidelines if we want to survive or contribute to an evidence-based medicine. Now, what are these guidelines? They help us to write a case in a better way. Majority of the things we are doing, but we just need to, have the codal formalities. For example, if we want to improve the quality of case, now how we can improve quality of case, we'll come to that part later. To improve the art of writing an evidence-based case, to promote accurate and methodical reporting. For example, you must have seen case reports and case series. Well, case record is a single case. Case series, that you took a case of similar diagnosis, or like, for example, you took 10 cases or 15 cases or 20 cases of psoriasis, and you presented the descriptive data collected at one place that I treated 50 cases and 45 responded. So those 50 cases need to be written on a similar line. You may give medicine whatever you wish to, that's not a problem, but at least you followed one guidelines to write them methodically in one way. To be considered for publication, it is suggested that cases should follow care guidelines, and if they are appended with the homeopathic specific guidelines, the chance of rejections are lessened. Now, this, especially to the youngsters, I get many calls or many emails every month that, sir, I want to get my case published. How to publish that case? I have the ultrasound reports with me. Now, these reports are nothing if you don't know how to present the case. So you should be knowing the art of that case record. So these guidelines, they will help you in that. There are certain included items in that, which are the must items. For example, type of homeopathy. When we go to scientific writings or the case records or the scientific journals, we always see that it would be written that individualized homeopathy was followed, or maybe there are many researches on formula also, even the single or the multi-constituents also, isopathy also. We don't do, that's our problem. That's not a universal problem. People are giving formulas, people are giving single constituent medicines, people are giving multi-constituent remedy, and these are being published and presented. Isopathy. So what was the type of homeopathy we followed? And if you're writing it well, there is no problem. There is no problem whether you followed the individualized or the isopathy. Now, the constitutional word is obsolete now in scientific journals. There is no constitutional treatment like thing we follow in our clinical practice. Yes, we follow. With due respect, we follow. But when we write, it is individualized medicine because it was adapted for that individual. So always and always in your scientific writings, or if you're presenting somewhere, use this word. The individualized homeopathy was used, means you adapted your line of treatment or your style of treatment according to patient's need. You may be single dose prescriber, no problem. But what if an acute problem came in between? Did you give the single dose? No, you gave the multiple doses. You gave the repeated doses because it's Hahnemann's guidelines given in organ of medicine, read 245, 246, 247, that we can repeat the medicines whenever needed. So it was individualized. Next is the medication. The nomenclature is important. We write PULS for pulsatilla, someone write pulsatilla. We write BRY for Brineia, someone write Brineia alba, they write BRYEL. Once I wrote S/L in my pharmacy in the hospital where we will have internship. We write S/L. It was a circumlectus. And the patient came that, sir, this medicine was not available in the hospital pharmacy, and I got it purchased from the outside, and he showed me sulfur 30. Because the pharmacist could not understand what is S/L, so he gave sulfur. Or maybe people, sometimes mistaken as a Cilicia. So the nomenclature is important. The list individual prescription is important. What were the constituents? What was the manufacturer, the potency, the scale? It is important. Because in one case, we can use N potencies. There is no problem, but we should mention those potencies, those dosage, repetition, or galenic form. For example, if we are reading a case study from Europe, they may be using K potency, but we are using the C potency. What they did, they give 30. That was 30D. What we give, it was 30C. So that dosage, repetition, and the right, basically, it is basically what, the best of writing you can do. Whatever do you do methodically, it is important for that case record. Then consultation, clinical history details, the homeopathic symptoms used for decisions, and the follow-up and outcome. Now, let me tell you one very interesting incident which happened a few weeks back when I was teaching to my students. We all take a case, we all deduce a prescribing totality. Am I right? Yes. We all do case and we prescribe on the basis of prescribing totality. Now, this is where the catch point is. We do not prescribe on the prescribing totality. We prescribe on the presenting totality because we have 15, 20 symptoms in our totality of symptoms. But we don't take those 15, 20 symptoms. Why? This is not characteristic. This is common. This is low grade. We reject symptom and ultimately on 4 symptoms only we prescribe. So basically it is the presenting totality on which we are prescribing. We take 50 cases, 50 symptoms, we repertoire 50 symptoms, and we only get 10 hotshot remedies, natramur, lacasis, sulfur, just like that. Because we are taking 2 broad rubrics, 2 broad symptoms, and the broader remedies come, and these broader remedies come, and these broader remedies have the broader symptoms or the remedies. So this consultation, this clinical history details the homeopathic symptom, the presenting totality, the prescribing totality, and totality of symptoms should be mentioned very clearly. It means I have 20 cases as per my totality of symptom for that patient. But I took those 4 prescribing totality points to prescribe. Whether they correlated with the materia medica, now this is again a matter of study, that whatever we are providing, that whether it had correlation with that. Now, next is follow-up and outcomes, possible casual attribution of changes, which are being assessed or discussed. I told you, we cannot follow patient for lifelong and we present a case. We had to stop somewhere. We need to draw the line that this was the line, this line we drew, and followed that patient and presented that. You treat the patient, no problem. We took a clinical study for 3 years when we were in Sood College in 2008 till 2011. So for study part, we followed the patient for 80 months. But we treated those patients for 3 years. But we had to cut short that period to 18 months because this is how we can compare our study and result with homeopathic point of view. Occurrences of homeopathic aggravation. Now these are part because we need to define whether it was a homeopathic aggravation or it was the disease aggravation. Now, there are certain optional items in this case record of the case care home guidelines. Consultation, individualizing symptoms reported. No problem. If you don't want to discuss, if you want to keep these items optional, you can do that. The prescription, the provision of repertorization data. See, the repertorization data is not mandatory. Many times, youngsters, they ask, sir, we have not appended the repertorization sheet of one case record. It is not mandatory. It is an optional item because even you can prescribe on the symptomatic totality. You can prescribe on the prescribing totality. You can prescribe on the materia medica knowledge of yours because you have picked up those symptoms. Follow-up and outcomes, assessment, disease, evolution in accordance with the homeopathic principle. Example, Herring law. It is not at all a compulsory item. Even if you're not following any such law in your case record, it is okay. Prescribing strategy, totality of symptom, keynote, essence, etiological. Yes, it is optional. What strategy you follow? For example, I prescribed on the basis of miasms. It was a miasmatic prescription. If I can describe that miasmatic prescription in few lines that I saw these symptoms or states or the patient's occurrences, all the family history, all the tendency, and I prescribe this anti-miasmatic intercurrent remedy. That's it. I don't need to prove it that this is valid, because this is already given in our philosophy, in our materia medica, that these prescriptions are valid. I just need to have a logic of that. Now, the issue is logic. If we can have that logic, that yes, on this logic, we prescribed, you have a good written case record. The next point is individual remedy related symptom are identified and analyzed. There's no problem because we are not going to clinical verification. Now, I'm telling you the plus points of these guidelines and the weak point of these guidelines. Now, there are certain checklists. Even, if you want to have a research on your clinic, at your clinic, you can have all these checklists right in front of you, the title. The word case report should be there. So whosoever is reading that case report, he should be very well, ease out that I am reading a case report. I'm reading a case series. Keywords. The key element of the case should be 2 to 5 keywords. Why? Because nowadays, everything is indexed. If you search Saurav Arora, my website would be there, sauravarora.com, because it's on my name website. The keywords are matching with my website name. People are searching best doctor for psoriasis treatment, best homeopathic doctor for psoriasis. If your case records, your web pages are appended with these keywords, that psoriasis, doctor's name, case record, treated, it is apt to be picked up by the search engines. It is important because whatever you publish, if you go to PubMed, if you search an author's name, the articles, they come and the keywords also come. For example, if you search autoimmune thyroiditis, in mass homeopathy, you would have article which I was part of that research in 2008. We had a research on autoimmune thyroiditis. We followed 194 cases of subclinical autoimmune thyroiditis in children in 6 to 18 years. Now, that is the biggest data or the sample size in thyroid disorders in homeopathy till date. It was published in 2010. It's been like going to be 15, 14 years now. Still, people, they search autoimmune, thyroid, homeopathy, that study comes in PubMed. So these keywords are important. Introduction. What is the uniqueness of that case? What medical literature do we have? Because nobody wants to listen to simple things. And this is, let's be very frank. If I am going to present a unique case or a case in a unique manner, the people's interest would be intact for the next 1 hour. What if I say I treat cough? Would you listen to me? I treat thyroid. Would you listen to me? No. When I say that I treated thyroid and I give this anti-miasmatic intercurrent remedy in this potency, that is the interest of yours. That uniqueness is there. The main symptom of the patient and the important findings. Now, this all Hahnemann has said. What are the presenting complaint? What are the history presenting complaint? What are the characteristic symptoms? Because these characteristic symptoms build up your arsenal also, your experience also. If I talk down the line after 10 years, I would be more confident. Why? Because I would be having then 28 years of experience. And I would be telling, okay, my 28 of year experience, I saw these symptoms. So that symptom of patient is important. What responded to that medicine? The main diagnosis, nowadays diagnosis, you cannot give a patient a medical without a diagnosis. What would you write? Totality of symptom? No, you would write the patient is suffering from maybe clinical diagnosis, a migraine or a headache or a pain abdomen or fever of unknown origin. You need to write something on the medical, on the fitness certificate. You cannot, discharge a patient without a diagnosis from a hospital, even from a homeopathy hospital. So that diagnosis is important. That disease knowledge of horizon 3 is important. Now, conclusion. What are the main takeaway lessons? I run few
I run few close group WhatsApp groups. So we discuss cases. So what are the takeaway messages? Whether it was a unique or it is just like, okay, fine, everybody is using gelsemium. What is the beauty of gelsemium in this season? What is the beauty of gelsemium 30 in certain cases? So that uniqueness, that takeaway lesson should be there. Now, introduction should be brief summary of the relevant medical literature. If you're dealing a PCOD, you should know what is PCOD. Just can, okay, fine, the female did not have menses and it was PCOD. No, you should know what is PCOD, what the patient came from, what was the main symptom, what was the relevance past intervention in that case, clinical findings, or the history details. Now, these are all case taking performa we are doing. But if we know what is to be written in that, we know that it is a good case record. Diagnostic assessments, challenges, because if you can present a case of rare diagnosis, people will clap for you. Even if you have not cured that case, even if you have treated that case, gave some symptomatic improvement, people will clap for you because that was a rare case you took in your practice and it responded well. What was the prognostic characteristic? Did your medicine took care of the recurrent allergies or the recurrencies? Yes, we do that, but we need to write that on paper. Now, the therapeutic interventions, the type we have discussed about the type of interventions, the type of homeopathy, the nomenclature we have all discussed. So I'm skipping these quickly. Now, I think we have all these things are done. The takeaway message, the patient perspective, the informed consent. Now, this is important. If you're presenting or writing a case anywhere, we should have that informed consent of the patient. It's a language varies from state to state or college to college. We can have already built or already available consent forms, and we can get them signed from the patient. Now, again comes the question, does social media sharing of a case is allowed, or does this sharing at par with the peer reviewed or journal publication? Now, this is a debatable topic. Yes, at certain places, I would suggest, especially the young generation, not to share the confidential information of the patient. It is unethical. It is not right. It is not as per the etiquettes we are taught with being a homeopath. So you can, share your cases and snapshots. You can take the snapshot before, after, it is allowed. But do not share the confidential information of the patient on social media, right? And this is not at par with the peer-reviewed publications or the journal publications. So I cannot write in my resume that I presented 100 cases on Facebook. It is not mentioned anywhere, and I should not mention that. Now, the conclusion is that there is a need to improve the quality of cases that are preserved, presented, and published. Always we preserve this. If I ask you, you may be having of your original case taken by you in past 40 years, you would be having that. I have the one of the earliest case I took in 2006 of a patient. I still, have that card with me, and I feel happy about that. I took the first case formally outside the internship module, so I have preserved that. Whatever I presented, whatever I published, I need to improve that. To achieve this, we need to adopt a uniform guidelines. These guidelines, they do not they're just to preserve the art of case taking. They're not to replace the case taking process. Whatever you do, you do, but just try to learn how to write, how to present. So we need to work upon the improvement, and yes, stick to the rules. Logic should be there. Process the case with two aspects in mind: the homeopathic case aspect and the nosological aspect. The diagnosis of the disease and diagnosis of the patient. Each information must be complete, and there should be a description: why this remedy, why this potency. And you can follow the guidelines, and if you are okay, you can just leave a message or just write to me on this email. I'll send you the copy of these case record guidelines. So because arranging every bit of information methodically is scientific method. We are doing it for past like 100 and 200 years now, since the inception of homeopathy, since the time of Hahnemann. We just need to be more methodical now, because we need to safeguard homeopathy for tomorrow. So with this, thank you so much for your patient listening. And now the house is open for discussion and questions.